Today, we're on site for Day 3 of the ISPOR 2019 annual meeting in New Orleans, Louisiana. We will be recapping some of the top news presented each day during the meeting, and soon we'll speak with Dr. Yousuf Zafar, Associate Professor of Medicine and Population Health Sciences at Duke University School of Medicine and a medical oncologist at Duke Cancer Institute, and Dr. Lou Garrison, a Professor Emeritus in the Department of Pharmacy at the University of Washington. Welcome to HMC On Location. I'm Jamie Rosenberg. The third day of the conference covered several hot topics that require innovative ways of thinking about healthcare. First, there was a session on biosimilars and addressing the legal, regulatory, and coverage challenges. There was also a session that explored how meaningful models can be constructed for rare conditions. Finally, there was a session on the affordability of prescription drugs with high price tags as they continue to enter the market. Read coverage and watch additional interviews from the meeting at hjmc.com. Here with me now is Dr. Yousuf Zafar. Thanks so much for being here.
Thank you very much for having me.
So currently, how, if at all, are patient-reported process measures considered in value-based programs in oncology, such as OCM?
So I think patient-reported performance measures are making great headway, particularly in this new value-based environment that we're finding ourselves in oncology. If you think about the oncology care model specifically, the primary mandates of a practice involved in the oncology care model is to ensure that patients have access to their providers, that providers have electronic health records, and that patients have access to patient navigation. Those are all very important features of care coordination, but patient-reported measures are not a specific aspect of OCM, though I think practices who employ them either in and out of OCM will see that their patients do better.
Right. And ideally, how would these patient-reported measures be integrated into these care models? How, in a perfect world, would this work?
Well, that really depends in terms of the perspective you're thinking about. So from the clinical perspective, there's been a lot of work showing that it's not that hard to integrate patient-reported measures into standard care. There is an infrastructure investment up front, and that can be burdensome and expensive, particularly for smaller practices. From the value lens, though, it becomes a little bit more complicated because the question then becomes who should pay for the implementation of these measures within a clinical setting. Should it be a payer or should it be the clinic? And that answer is not completely clear.
Right. And what are some of the downstream effects of patients being included in this process? For example, do patients feel empowered and kind of want to take control of their healthcare and be more involved?
I think anytime we're asking patients directly how they feel and how they feel about the quality of their care, the vast majority of the time, patients are going to feel more empowered. What's really important about that process, though, is to make sure that information gets back to the patient so they can see how they've responded. I think that would help in terms of patient empowerment much more than just asking patients for their information, and then they feel that it goes into sort of a black box and they never see that data again.
And are there challenges with not only addressing differences in what matters to providers and patients, but also what matters to different kinds of patients, because every patient has a different experience with their disease and the healthcare system?
Absolutely. So how a patient responds to any measure is based on that own patient's frame of reference. And like you said, it might be very different for another patient. So to me, how to deal with that is to think about longitudinal measurement. How a patient responds over time. And that way you can gauge where a patient falls in relation to others in terms of response and change over time.
And are there actions that payers can take to ensure a smooth implementation when considering the use of patient-reported metrics in value-based healthcare?
So I think the first step for payers would be to understand that patient-reported metrics can improve care. Patient-reported outcome measures can improve patient survival in terms of patients with certain cancers. So outcomes are better, patient engagement might be better, and you might even see decreased costs down the road with adherence, fewer emergency department visits, and better care quality overall. So if payers understand that the upfront investment is potentially returned over time, I think that would be an important first step.
Right. And what other challenges exist for successfully incorporating these measures, such as taking what matters to a patient and translating it to meaningful metrics?
Yeah, I think you said the key word there, right? Meaningful. There are a lot of metrics available right now, and not all of them are meaningful to the patient, the clinician, and possibly even the payer. So understanding how to identify the appropriate metric is critical. I think that's one of our biggest barriers right now, is making sure that we're implementing metrics that are meaningful to all stakeholders.
And what are some key strategies for closing these gaps and trying to mitigate some of these challenges?
So stakeholder involvement, I think, is a key strategy. And by stakeholder involvement, I mean clinicians, patients, payers, and possibly even manufacturers. If we are all on the same page in terms of what we all identify as meaningful, I think that's a big step forward in implementing these metrics in standard of care practice.
And speaking of multi-stakeholder, do you think that caregivers or care coordinators also have a role in this because they're kind of working hand in hand with the patient?
Absolutely. And I'll tell you, so often, particularly in my research, I see caregivers oftentimes completing the measures on behalf of patients. And we need to acknowledge that. We need to acknowledge that caregivers play an incredibly important role in patient care, and we need to focus more, in fact, on capturing caregiver-reported metrics as well.
Great, thank you so much.
It's my pleasure.
Here with me now is Dr. Lou Garrison. Thanks so much for being here.
Pleasure to be with you, Jamie. Thanks for doing this.
So the quality-adjusted life year is a commonly used measure for determining the cost-effectiveness of a drug. How has the use of the QALY increased in recent years, and what do you think are the drivers behind this increase?
Well, I think the QALY's actually been around a long time, over 40 years now. There are over 7,000 studies in a database maintained by Tufts University. So it's been around a long time for a good reason. It's actually a pragmatic, simple measure to allow us to compare very different kinds of technologies, because health plans have to do that. And it's not so easy to rely on healthcare markets since people aren't voting with their own money. So we use that, I think it's really a workaround to let us compare different technologies to try to decide whether to bring them into the health plan. And it's a pragmatic measure. It tries to combine two simple components of health gain, the length of life and quality of life. So you say, well, what's not length of life? You could say, or what's quality of life? Well, it's everything that's not length of life. It's a simple answer. It's supposed to capture everything. In practice, it doesn't capture everything, and so there's some limitations that we've had to deal with. But it's been around a long time, but in the United States, we've been averse as a society to making hard decisions about medical technologies. Because of cost pressures, we're increasingly trying to make those decisions. And so I think we're turning to that tool, and we see it in a greater embracing of the tool, in particular by an agency called the Institute for Clinical and Economic Review, ISPOR, that has promulgated the use of that tool. And it's from really a nonprofit private organization, and it's really an open question as to how successful that will be at this point.
Right, and so there is some controversy around the QALY. Starting off, what are some of the benefits of it? Why is this a good measure to have?
Well, as I said, I think I tried to say the main benefit is that it lets you compare very different kinds of technologies. In terms of outcome, you have to decide, you have a limited budget, you've collected a certain amount of, you being a health plan, a certain amount of revenue for the year, a certain amount of premiums. They have to decide how to allocate the money. New technologies are coming, they have to decide which ones to pay for, so they want to be able to compare them. If you think about it, we would certainly always look very closely at the clinical data and say, does it look like a good thing or not? But at some point you may have to make a choice between one or the other, or one in a bigger population, another in a smaller population. So it's a tool for letting you do that. And I think that's the big plus, is just a tool for letting us think about those very difficult questions. And we can talk about the limitations at some point. I don't know if that's your next question, but.
Yeah, that's a perfect segue. So what are some of the limitations? What doesn't it take into account that it should? Things like that.
Yeah, I think that one of the major concerns comes from sort of the way it's constructed on the utility side. And I think it's always important to recognize there's survival side, life expectancy, which is very much based on epidemiological methods. But there's also the question, what is the quality of life you're experiencing in a certain health state? So if you were on kidney dialysis, going in 3 times a week, experiencing some adverse events, we might say a simple way to think about it, on a scale where 0 is death and 1 is perfect health, where would you put that? 0.5, 0.6, 0.7? Well, we see, obviously people differ. Everybody has a different valuation of these things, but on average in that situation it's between 0.5 and 0.6, say. So it gives us an idea of what we're getting. So if I said 10 years, if dialysis gives you 10 years at 0.6 and some other therapy gives you 10 years at 0.2, then you'd say, well, I'd rather put my money in the one that's giving me more. And so it lets you do that. Now, the problem, one of the the utility side, and this is where people understandably have concerns, is that the utility index assumed that going from 0.2 to 0.3 is the same gain as going from 0.7 to 0.8. But you might say, if I ask you, what would you do if you had to make a choice for a fellow citizen or plan member, would you rather spend it on the person who's at 0.2 or the person who's at 0.7 or 0.8? And most of us would say, well, we would adjust for severity of disease and give some preference. So people are working on how to incorporate that better, but I think we all recognize that as a limitation. The other thing is, and our task force at ISPOR addressed this, the quality's kind of base it's a model. It's a simple mathematical model tool, essentially, and the way it's calculated makes a lot of assumptions that may not be valid all the time in certain situations. Doesn't work well for children. It may not work well for people in end-of-life situations. Makes a lot of assumptions, and it leaves out a lot of things that aren't related to certainty, like the peace of mind you get from knowing you're going to have access to an effective technology. So we know that provides value, but it's not in the calculation.
Right, and given these different limitations, what concerns are there with using the QALY as a basis for coverage decisions? Most notably, we hear of CVS allowing coverage based on the QALY, so what concerns are there?
Well, the concerns are that it's a pragmatic and it's an imprecise tool. And so, while I would applaud the idea of certainly trying to think through, a threshold, but I guess I would also, a threshold, and how you might have a formulary that dealt with a threshold, but if you don't also say, well, wait a second, we need some flexibility in that threshold because we know that our calculation doesn't perfectly capture everything that we want. The other thing is we may be willing to pay more than a given threshold for certain kinds of conditions that are more severe. So the idea that you can do it with a simple threshold is a challenge. And the other big challenge is it's a daunting task to apply it to the entire formulary. And it's kind of a moving target also because prices change, values change, and I assume it would be an administrative challenge, but I certainly think different insurers could attempt to do that and see how it works, and we'll have to see how it works, I guess.
Right, and despite these limitations, this isn't a measure we should just overhaul and get rid of, and instead we should adjust it. What are best practices for maybe addressing the challenges or the limitations of the measure?
Well, I think people are actively looking to research to allow adjustments. But and I think we do make adjustments, and we look at different subgroups, and we look at lots of other things that are effectively adjustments. But I would say that people are looking into it, and I think that the final kind of adjuster is most of our processes around coverage are not going to be based on some mathematical calculation entirely. It's a group of people making a judgment for a health plan. So they're going to certainly have the opportunity to factor in on a qualitative basis other considerations. Now, ICER labels this category, other benefits and contextual considerations, because it's very hard to apply, because you can think of medical technologies that not only affect the child, for example, but implicitly they affect the parents. And suppose I that I save a child, but they're disabled, then I affect their lifetime spending on disability and education. And so the boundaries can be quite broad. So we need to be flexible enough to be able to consider other things that come into play.
Right. And are there also challenges with using traditional cost effectiveness when determining the value of drugs for rare diseases due to factors of incomplete understanding of the natural history of the disease and appropriate endpoints?
No, those definitely make it a challenge in the area. Did you say gene therapies per se?
Yeah.
So gene therapies, it was interesting that so much of this meeting was about gene therapies, because they're really amazing breakthroughs. And we do face the challenge, how much do we want to reward the innovator? I mean, how do we decide what that is? And I think the quality is a good starting point, and we can sort of say that, look, if you save a life, a person is expected to live 80 years. By our calculus, we do a calculus that discounts future life years down to 30 years, and we can start to think about what it might be worth. I mean, ISPOR uses a threshold value of 150,000 per quality. So per life, essentially per life year, if you multiply that by 30 years, that's 4.5 million, which is a big number. And but people would also argue that it's clear that we do kind of seem to have a revealed preference in society that we do spend more for people in rare catastrophic situations. So the health catastrophe is important here. We're talking life and death in many of these situations, and these gene therapies can keep people from a life of suffering. So they're worth a lot. And I think that our methodology is a good starting point, but we do face decisions, and we're going to have to grapple with these. What are we willing to pay for this? But as you say, it's not an easy decision also because we don't really know the outcome. They're based on small trials, limited number of people, short duration, and yet biologically it looks like we're going to save them for 80 years, but what if we don't? Have we paid too much? How do we do that? So there's lots of research, and we'll hear more about it in the plenary tomorrow. New Digs and MIT in particular has thought a lot about how to finance these things, which is a big challenge. So we face a big financing challenge.
Great, well thank you so much.
Nice to talk with you, Jamie, thank you.
That's all from the ISPOR 2019 annual meeting. Thank you for watching AJC News Network. I'm Jamie Rosenberg.